See that? If that's there, I'm recording. If that's not there, I'm not. Okay? All right, so like I said, we do systemic anatomy, but there is another way to do anatomy, and it's also really good. It's kind of for a different person or different purpose. It's called regional anatomy, and regional anatomy is the way that they do it in med school. So instead of, for instance, in med school, you learning the systems, you would learn regional anatomy of the arm, right? So for instance, you would learn all of the musculature, all of the nerves, all of the vessels, right? And all of the bony landmarks for a region. You can understand why that would eventually be more relevant, right? So it has advantages, but it doesn't give you a systemic understanding of how the body systems are related to one another. So usually that's done at the graduate level or in med school. So if you have to, what I'm saying is if you have to take anatomy again in med school, it's going to be a different class, but it'll be really related to this one. Although Martin Nielsen of the U, he does regional anatomy at an undergraduate level. He's pretty much the only one who does regional anatomy at an undergraduate level, and he does all dissected cadavers. So instead of like looking at a cadaver, he hands you a leg. Here's a leg, and you're like, oh, leg day. Okay, so that's regional anatomy. There are other branches of anatomy. I'm not super good at any of these. I throw them in just for fun. There's surface anatomy. Those of you who are nurses or nurse aides probably are better at surface anatomy than I am. Surface anatomy is using external landmarks to figure out where internal structures are. So you know when your doctor is like rooting around, making your boob move up, or if you don't have boobs, just like finding between ribs 3 and 4, that's where the heart comes into contact with the anterior wall of the thoracic cavity so you can hear the heartbeat best. That's surface anatomy. Or if you feel down below L2, that's where your spinal cord ends. So if you're going to poke something, you don't want to poke there. You want to poke below there, right? Or the anterior superior iliac spines right here. These guys, if you can still feel them after the holidays, mine used to be slightly close to the surface. If you can still feel them after the holidays, that marks the boundary of your pelvic cavity and your urinary bladder is under there. There's a bunch of surface anatomy, and eventually, if you guys go to medical professions, you'll know a hell of a lot more about that. I don't do surface anatomy, I just take skin off if I want to see it. I'm like, hey, what's under there? So there's also developmental anatomy and embryology, which are kind of related. It's like getting you from the zygote stage all the way up. And sometimes developmental anatomy is really interesting. For instance, the developmental anatomy of the reproductive system, how we all started out with ductwork to become either sex. And then the switches that happen that make you end up developing into an anatomical male or an anatomical female, that stuff's kind of interesting. Pathological anatomy, most pathologies are phys problems, but sometimes they can be anatomy problems too. Like scoliosis, right? That's a path anatomy problem, right? Or cleft palate. So I throw those in every once in a while because they make the story more interesting. And if you can see abnormal development, sometimes the normal development makes a little more sense. Okay, so if I do it well, anatomy naturally leads to physiology. So what should happen when anatomy is being taught well is that you'll start having the phys questions, right? You'll start going, oh, well that seems like, And sometimes you'll ask me, and sometimes I'll say, that's a phenomenal question that takes 45 minutes to explain in physiology, but if you want to come to my office, we can definitely talk about it. So it will definitely suggest phys. Go ahead.
Will any of these cadavers have scoliosis or anything? Are you allowed to say if you have scoliosis?
COPD and things like
Yeah, they've got a whole bunch of weird stuff. We don't have any with scoliosis. We do have one. The one that we just got has a broken pelvis. We have them with extra branches. They've got COPD. They've got cancers. We have their offered medical history, and sometimes your lab instructors and lab aides will be able to tell you that. Okay, they don't tell you their names because that sort of violates the confidentiality, but we can tell you relevant stuff about them, and sometimes they're super fascinating, interesting. Especially the one, we've got one with emphysema, and I don't know if you know what emphysema does to the lungs. The lungs are like, instead of being like really dense, the lungs have like huge holes in them. Like it's a good non-smoking. Here's why you don't smoke. Look at this. So yeah, there's cool stuff about every cadavers and abnormal stuff or pathological stuff about cadavers. We used to have one with scoliosis, but I don't think we do right now. They have to go back every once in a while to the body donor program. Okay, so briefly, this class ends at 11:20, right? Okay, briefly, let's talk about introduction to gross anatomy and how we're going to meet gross anatomy. Okay, so first thing is, if you want to talk about gross anatomy, we've got to get a common set of assumptions so that, for instance, if I found an anatomical structure, or let's say I found an anomaly and I wanted to describe it to someone who was in Israel, regardless of the fact that we don't speak the same language, we have to use a common anatomical language, does that make sense? And a common set of reference points. So for instance, we have to standardize that, and that's what we're going to do first. So first thing is there are directional terms, we're about to go through them. The first one is that there is an assumption of what we call anatomic position. An anatomic position is if you are standing up, it is toes forward, palms forward. I'll describe why in just a second. Thumbs out, okay? So this is anatomic position. That means that this, my palm, and this part of my forearm corresponds to an anterior surface of my body. Not because it's comfortable. It feels weird. I'll tell you why in just a second. Okay, and then patients aren't always standing up, right? So anatomic position laying down is either supine or prone. Who knows which one is laying down face up? That's supine, right? Okay, but still, regardless of whether you're supine or prone, this is still considered anterior, right? And prone, you can't get to everything from the front side, right? Sometimes you have to lay face down, right? So still anatomical position, right? That makes sense? Okay, so I always remember, because you can drink soup if you're supine, and if you're prone, you can pull it out. Supine, prone. Makes more sense if you're from Texas, because you do post stuff out in Texas. Okay, so anatomical position, either way. So the deal is that regardless of how I change my position, right, I can do whatever I want with my body. This is still an anterior structure. This is still a posterior structure, regardless of the changing position of my body, right? So I don't care what you do with your leg, this is still the muscles of the anterior thigh, right? Even if I'm flipped around, okay? All right, so supine and prone. And then let's address why anatomical position is weird in humans. Because this is not particularly comfortable, right? It doesn't even seem particularly logical. So why? It's because we are a biped, we are a bipedal organism, a bipedal mammal, but is that the exception or the rule? Is bipedalism the exception or the rule with mammals? It's the exception. Most mammals are quadrupeds, right? So think about your dog for a second. And now tell me whether this part and this part corresponds to the belly side of your dog or the back side of your dog. Doesn't this all correspond to the belly side? Okay, so the same muscles that I would find on my dog here, I find on me here, right? If I didn't do that and I said, oh, this is anterior in human, this is entirely different musculature, entirely different innervation, entirely different everything, right? Right? So this, the reason humans have to stand weird is because this is how we really should be in textbooks, but that takes a lot, right? So we'll just do it this way, right? So this is the anterior surface. Does that make sense? Okay. So now, left and right are also super important in anatomy. Have you guys read the stories that I have about somebody getting the wrong kidney taken out? The wrong eyeball operated on, right? The wrong knee operated on. Why does that happen? It happens because you didn't create this habit right here that you need to create. Right and left is very important. Not only are we bipedal, but we're also bilaterally symmetrical, right? So we have an imaginary midline and mirror image structures, especially externally, not all internally. So here's the deal. There are a lot of paired structures in humans. If there is a paired structure, you are responsible for left and right, without exception. I will take off at least once this semester to make you learn that lesson. So for instance, this is not my ear. What is it? It's my right ear. Yes, this is my right ear. Exactly. Does that make sense? Okay. So I reserve the right to count and answer completely wrong if a left and right is required and you do not put it. That makes sense? So you need to be more specific in anatomy. So you need to be specific about lefts and rights. Now, do you guys know what they do now in surgery? if you're having, for instance, an elective surgery, or you're conscious before surgery, what do they
You
do?
have to write on.
You write it.
A plate put in here.
Yeah.
You have to write on your hand. We wrote on my hand. Somebody else. There were like 3 S's on this hand.
Yes, right.
Even though it had a splint on when I went to surgery.
And you have to write it too, right? You have to write yes, no, yes, no.
Yeah.
And do you think it's because they're really concerned and they don't want to be sued? And they're like, she wrote it. I'm here. And I'm like dreading the day that one of my students is responsible for taking out like the wrong kidney. And I know they would have been long past that by then, but if it goes back, they're like, they took anatomy first from Melanie. I'm like, damn it, there went a kidney. Okay, and as far as left and right goes, left and right is also always the cadaver, the specimen. Nobody cares about your left and right. So what you have to do, and you see people doing this in labs, you have to empathize with the cadaver, right? You go like, right. However you have to do it. Everybody looks stupid in anatomy lab, and nobody's looking at you anyway. It's like yoga. If you look at somebody else in yoga, what happens? You fall over. That's what happens. Okay, so left and right is always referring to the specimen or the cadaver. Okay, so directional and regional terms. Let's get you started. You're going to be doing this in lab this week as well. So first, orientation and directional terms. A lot of this you know because you've been a human for a long time, but some of it is a little less intuitive. So let's look at the directional and regional terms. All right. So there are ways to refer to things with directional and regional terms. Let's start with the easy ones first. If you are discussing two structures with reference to one another, you can say that they are superior and inferior to one another, right? Okay, and that's super easy. My nose is what to my navel? Superior. My navel is what to my nose? Inferior. However, does that work with your dog or your cat? No. So there is another set of terminology that is more consistent with superior and inferior and more applicable to all species. So does it make sense to you that a cat's nose and navel are not superior and inferior to one another, right? So what set of terms could we use that would be applicable to both situations? We can use the next pair of terms, which is cranial and caudal. Have you guys heard of cranial and caudal? Okay, cranial and caudal is toward the head or toward the tail, right? Cranial is toward the head, caudal is toward the tail. If you fish, what's this fin called?
Dorsal.
No, this one's dorsal. That one's caudal, okay? So now let's do the same pair, right? It's going to be true both for me and for my cat. I don't own a cat, I own a golden retriever. But my dog. So my nose is what to my navel. We use that pair of terms. Cranial, right? My navel is what to my nose? Caudal, right? Is that also true for my dog? Yes. Does that make sense? So it doesn't matter whether you're a quadruped or a biped with cranial and caudal. So which one are they going to use? Yes. Whichever one they feel like using, honestly. Superior and inferior is pretty common, but cranial and caudal does occur. Okay, anterior, posterior, you know those, right? So anterior structures, posterior structures. Anterior structures, my nose is a what structure? Anterior, my coccyx is a posterior structure, that's cool. But that's again not true for my cat, right? Do you see that it's not true? Okay, for my cat, actually that one kind of is. Let's use vertebra, right? My nose is anterior, my vertebrae are not posterior, right? They're on top if I'm a cat. So is there a pair of terms that's more dependable and more applicable to multiple species? Yeah, there is. And that is dorsal and ventral. Okay, and those are used all the time. Okay, so dorsal and ventral. Now I'm going to ask you again, what's this fin called back here? That's the dorsal fin. And this is ventral. So basically dorsal means backside and ventral means belly side. Okay, so instead of something being labeled, the anterior forearm, they'll say ventral muscles of the forearm or dorsal muscles of the forearm. And then you have to know two things. You have to know anatomical position, right? And you have to know that ventral will be associated with the belly side and dorsal will be associated with the backside. Does that make sense? So ventral and dorsal are really, really commonly used. You're going to need to use those. Okay, and then medial, lateral, and intermediate. Okay, so this one's not too bad. We'll be able to finish these just before you guys leave. Medial and lateral, because we're bilaterally symmetrical, we have an imaginary midline, right? And if you're close to it, you're described as being medial. And if you're further away from it, it's described as being lateral. So let's do this. My nose is what to my ears? Medial. My ears are what to my nose? Lateral. Does that make sense? And what about intermediate? What if I had, I do have a mole right there. So this is lateral, this is intermediate, and this is medial, right? That makes sense? Okay. Now, anatomical position. My thumbs are a what structure? Lateral structure. Exactly. That makes sense? Now, you don't just use it for the whole body, you also use it for parts of the body, okay? So if this is my forearm, and of course this is the ventral surface of my forearm, right? But this is the lateral surface of my forearm, and this is the medial surface of my forearm.
So would you say lateral ventral, or would you say ventral lateral?
It's one. Either one. Doesn't make any difference which order you do it. That makes sense to you guys? Okay, so for instance, there are muscles right here. These are the muscles of the medial thigh. These are the muscles of the lateral thigh. These are the muscles of the anterior or ventral thigh, and the muscles of the posterior or dorsal thigh. Does that make sense? Okay. Last one is the one that people have the most trouble with. Oh, last two. Proximal and distal are the ones that people have the most trouble with. But will you write this down so you don't have trouble with it? Proximal and distal is used in a specific circumstance. And it's used for limbs or tubes, long skinny things. Okay? And it's specifically used to describe things along the length of limbs or tubes, because limbs or tubes are wiggly and they don't always stay in the position. Think about if I was trying to describe the site of an intestinal blockage, and I was just using superior, inferior, medial, and lateral, but it wiggles, right? So what could I use that would be more dependable? I could use distance from a stable structure, right? A point of attachment, right? So let's do the arms, and then you'll think about the guts. Okay, so let's say wrist and elbow. Proximal means closer to the point of attachment, and distal means further away. What's the natural point of attachment here? Shoulder. Okay, my wrist is what to my elbow? Distal. My elbow is what to my wrist? Proximal. That means that superior and inferior are incorrect with limbs or tubes. You don't use them. Okay? Does that make sense? Okay? You don't use proximal and distal on the trunk. You don't use superior and inferior on limbs and tubes. Does that make sense? So now if I was, for instance, trying to tell someone where an intestinal blockage was and I was writing it down, I'd say it's 10 centimeters distal from the iliocecal sphincter, right? You don't have to know what any of that is, but they would, right? You're like, I start here, I go 10 centimeters distal. Does that make sense? Okay. And the last one, and I'll let you guys go, is superficial and deep, and that's easy. Just think about personalities or wounds, right? Okay. Superficial means close to the surface, and deep means away from the surface. So imagine yourself as a sphere. If you have a deep wound, you will go through multiple layers. Other ways that you will use it, muscles are layered on top of one another. So I will have superficial musculature, and then deep to the external oblique will be the internal oblique. And then deep to that will be the transversus abdominis, right? So they can layer. So last one, and I'll let you guys go. Describe the skin with reference to the muscle. The skin is what? Superficial to. Now describe the bone with reference to the muscle. Deep to. Does that make sense? Okay, we'll pick up there on Thursday.